You wake at 2 in the morning needing to urinate. You blame the water you drank before bed, or the tea at dinner, or your bladder. Maybe it has weakened with age. Maybe it cannot hold what it used to. If you are male and over 50, you blame the prostate, the gland that wraps around the urethra and narrows the exit as it enlarges. Every one of these explanations is either wrong or incomplete, and the reason none of them explain the timing is that the timing has nothing to do with any of them. Something is filling your bladder at 2 in the morning that was not filling it at 2 in the afternoon, and the source is not your kidneys working harder, not your water intake, and not your bladder capacity changing. The source is your legs. The fluid that gravity deposited in the tissue spaces of your lower legs across 14 hours of upright posture is draining back to your heart now that you are horizontal, and your heart is commanding your kidneys to dump it. Your legs are filling your bladder. The physics has been doing this every night for years. The restless legs discussion described the fluid that accumulates in the calves across a day of upright posture, hydrostatic pressure driving plasma from the capillaries into the interstitial spaces, visible as ankle swelling, sock marks, shoes tighter by evening. That script covered what the fluid does to the sensory nerves. This one covers where it goes when you lie down because the destination is the bladder and the route passes through the heart. When you shift from vertical to horizontal, the hydrostatic gradient that was pooling fluid downward disappears. The pressure at the ankles equalizes with the pressure at the heart. 500 to 700 milliliters of excess interstitial fluid in the lower legs begins draining back into the central circulation through the lymphatic channels, through the veins, traveling what is now a level pathway rather than an uphill one. The fluid arrives at the heart over the following 2 to 3 hours. 2 to 3 hour transit time is the key to the 2 a.m. awakening. You lie down at 11, the fluid begins returning. By 1 to 2 in the morning, the central blood volume has increased by 300 to 500 milliliters as the leg fluid reaches the heart. The increase triggers a hormonal cascade that produces the urine that fills the bladder that wakes you at the exact hour when the redistribution reaches its peak. Now the hormone, because the heart has a volume sensor that most people do not know exists. Atrial muscle cells are not just contractile, they are endocrine. The atrial walls contain stretch-sensitive myocytes that produce and release a peptide hormone when the atria are stretched by increased blood volume, as DeBold and colleagues discovered at Queen's University in 1981. The hormone atrial natriuretic peptide, ANP, reframed the heart from a pump into a pump that monitors its own filling and commands the kidneys to adjust. When the 300 to 500 milliliters of redistributed leg fluid increases central blood volume, the atrial walls stretch. ANP releases into the circulation. ANP acts on the kidneys. It increases the filtration rate at the glomerulus, decreases sodium reabsorption in the collecting ducts, and suppresses the release of antidiuretic hormone from the posterior pituitary. Net effect: the kidneys shift from the water-conserving mode of sleep, which produces small volumes of concentrated urine, to a volume-dumping mode that produces large volumes of dilute urine. The kidneys are processing the redistributed leg fluid because the heart detected the volume increase and commanded a dump. The bladder fills not from the water you drank at dinner, but from the plasma that spent 14 hours pooled in the tissue spaces of your lower legs. You wake, urinate, return to bed. If more fluid is still redistributing, the cycle repeats. The second awakening, at 4 or 5 in the morning, is the tail end of the redistribution completing. Well, what water restriction actually addresses and what it misses, because restricting water after 6 in the evening is the most common advice and the least complete. Water restriction reduces the volume of recently consumed fluid available for renal processing. It works partially for the component of nighttime urine that comes from recent intake. But the leg fluid component is not affected by water restriction at all. The 500 to 700 milliliters pooled in the lower legs was deposited across 14 hours of hydrostatic pressure, regardless of evening water intake. Restricting water after dinner addresses maybe 30 to 40% of the nighttime urine volume, the portion from recent consumption. The remaining 60 to 70%, the portion from gravitational redistribution, arrives at the kidneys on a schedule that water restriction cannot modify. This is why restricting water does not eliminate the 2 a.m. awakening. It reduces it slightly but does not prevent it, because the primary driver is not what you drank but what gravity deposited. The viewer who has been going to bed thirsty for years to avoid the 2 a.m. trip was solving the smaller half of the problem. Prostate explanation is equally incomplete, and the incompleteness explains why surgery does not always fix the problem. For male viewers over 50, benign prostatic hyperplasia is the standard explanation for nocturia. The prostate enlarges, the urethra narrows, bladder emptying becomes incomplete, residual urine volume increases, and the bladder reaches its capacity threshold sooner, producing more frequent urination both day and night. BPH is a real mechanism. It contributes to the problem, but nocturnal polyuria, increased urine production at night, is a different mechanism entirely. The prostate makes the opening smaller. The leg fluid redistribution fills the bladder faster. Two independent pathways producing one symptom. Male viewer who underwent prostate surgery and still wakes to urinate at 2 in the morning has addressed the outlet obstruction but not the volume overload. The opening is wider, but the kidneys are still processing 500 milliliters of redistributed leg fluid between midnight and 3 because the gravitational pooling mechanism was never addressed. Surgery fixed the prostate. It did not fix the legs. The urologist who did the surgery may not have explained this because the two mechanisms are managed by different specialties. Urology handles the outlet, and the gravitational redistribution is a cardiovascular and fluid dynamics problem that falls between specialties. The snoring discussion described a second nocturia pathway, apnea-driven sympathetic surges, triggering AMP release through a cardiac stress mechanism rather than a volume mechanism. The viewer who both snores and wakes to urinate may have two independent pathways filling the bladder at night, one from the legs and one from the airway, each requiring a different intervention. And then why it worsens every decade. Nighttime urine production exceeding 33% of total daily output. The threshold Weiss and colleagues defined as nocturnal polyuria in the Journal of Urology is present in the majority of adults over 60 who report nocturia. 3 age-related changes compound the mechanism independently. Venous valve incompetence increases with age. The one-way valves in the leg veins that should prevent downward blood flow become incompetent, allowing more fluid to pool during the day. More daytime pooling means more nocturnal redistribution, means more AMP release, means more renal output, means more awakenings. The veins that held the fluid back at 40 permit it through at 60. Lymphatic contractile function declines. The lymphatic pump that should drain interstitial fluid during upright hours weakens, allowing more fluid to accumulate before bedtime. Less daytime clearance means more fluid available for nocturnal redistribution. ADH production changes with age in a way that compounds both mechanisms. In younger adults, ADH levels rise at night. The posterior pituitary increases antidiuretic hormone production during sleep, reducing renal output and concentrating urine, so the bladder fills slowly. In older adults, this nighttime ADH surge is blunted. The posterior pituitary produces less ADH at night, so the kidneys conserve less water during sleep even without the AMP signal from leg fluid redistribution. The age-related ADH decline and the gravitational AMP surge arrive at the kidneys simultaneously, one telling the kidneys to conserve less, the other telling the kidneys to dump more. Two independent hormonal changes, both driving urine production upward at the exact hour when the bladder should be quiet. 55-year-old who wakes once will wake twice at 65 and 3 times at 75, not because the bladder shrank or the prostate grew, but because the venous pooling increased, the lymphatic drainage decreased, and the hormonal regulation that should protect sleep-time urine production degraded from two directions. Diabetes adds a third pathway that operates independently of gravity and explains why diabetic nocturia does not respond to leg elevation. Elevated blood glucose exceeds the kidney's reabsorption threshold, and the excess glucose spills into the urine, dragging water with it through osmotic force. This osmotic diuresis produces large volumes of dilute urine day and night, regardless of fluid pooling. If you have diabetes and wake 3 times to urinate, two mechanisms may be running simultaneously: the gravitational redistribution and the osmotic spillover. Leg elevation addresses the first. Blood sugar management addresses the second. Calcium channel blockers, among the most commonly prescribed blood pressure medications for adults over 50, produce ankle edema as a side effect that feeds directly into the nocturia pathway. These medications dilate the arterioles in the legs, increasing the capillary hydrostatic pressure that drives fluid into the interstitial spaces. The ankle swelling calcium channel blockers produce is the gravitational pooling mechanism amplified pharmacologically, more daytime pooling, more nocturnal redistribution, more 2 a.m. awakenings. If you started a calcium channel blocker and noticed worsening nocturia within weeks, the medication is increasing the fluid load available for nocturnal redistribution. The connection is rarely explained because the prescribing cardiologist manages the blood pressure and the urologist manages the nocturia, and neither specialty routinely connects the ankle edema to the nighttime bladder. Women experience nocturia through mechanisms the male-dominated research literature has underrepresented. Pregnancy produces a severe version of the gravitational mechanism. Blood volume increases by 40 to 50%. The enlarged uterus compresses the inferior vena cava and iliac veins. Venous return from the legs is impaired, and daytime pooling is dramatically increased. Third trimester nocturia of 3 to 5 awakenings per night is partly gravitational redistribution operating on a much larger fluid volume. Postmenopause, declining estrogen reduces vascular tone in the leg veins, contributing to venous valve incompetence and increased daytime pooling. Estrogen also modulates ADH receptor sensitivity in the kidneys. The postmenopausal reduction may alter the nighttime water conservation response, compounding the gravitational effect with a hormonal one. Nocturia that worsened around menopause and was attributed to aging may be the estrogen-mediated venous and renal changes menopause specifically produces. Pelvic floor weakness, more common in women who have given birth, adds an outlet dimension analogous to the male prostate, reduced bladder support, urgency from detrusor overactivity, and reduced holding capacity that makes the AMP-driven volume increase more likely to produce an awakening. Two women with identical leg fluid volumes may have different nocturia severity because their pelvic floor support differs. You now know what fills the bladder and why it worsens. The question changes from what produces the urine to what you can do about the fluid before it reaches the kidneys. Physics of the solution is the inverse of the physics of the problem. If the nighttime urination is caused by gravitational redistribution of leg fluid after lying down, the solution is to redistribute the fluid before lying down while still awake in a controlled setting with access to a toilet, 20 to 30 minutes with the legs elevated above heart level before bed against a wall, on a stack of pillows, in a recliner with the feet up, allows the gravitational redistribution to begin while you are still conscious. The interstitial fluid drains from the legs, central blood volume increases, AMP releases, and the kidneys produce urine. You urinate before bed, processing the leg fluid while awake rather than at 2 in the morning. Redistribution takes 2 to 3 hours to complete fully, but the majority of the fluid returns in the first 20 to 30 minutes of elevation. Processing even 50 to 60% of the pooled fluid before bed significantly reduces the volume available for nocturnal redistribution, reducing the AMP signal, reducing the renal output, reducing the number of awakenings. First urination after elevation is diagnostic. If the urine is clear or very pale, dilute, high volume, the legs were the source. The kidneys dump the redistributed fluid under AMP command. If the urine is dark and concentrated despite adequate hydration, the mechanism is different and elevation alone will not address it. Morning body weight provides a second diagnostic. Weigh yourself at bedtime and again on waking. The difference, typically half a kilogram to a kilogram, represents the fluid the kidneys processed overnight plus respiratory water loss. If the overnight weight loss consistently exceeds a kilogram, the redistribution volume is large, and the gravitational pathway is likely the dominant driver. Minimal overnight weight loss suggests other mechanisms, osmotic, pharmacological, or outlet-related, are the primary contributors. Now compression stockings, because preventing the pooling is more effective than processing it after the fact. Graduated compression stockings, tighter at the ankle and progressively looser toward the knee, maintain external compression on the leg veins and lymphatic vessels throughout the day. The compression prevents the capillary to interstitial fluid shift that hydrostatic pressure drives. Less daytime pooling means less nocturnal redistribution, means less AMP, means less nighttime urine production. Nocturnal urination frequency decreased measurably when older adults wore knee-length graduated compression stockings during the day, as Vaughan and colleagues documented. The stockings did not treat the bladder, did not treat the prostate, did not restrict water intake, they prevented the gravitational fluid pooling that was filling the bladder at night. The intervention addressed the mechanism at its origin, 14 hours before the bladder filled. Stockings need to be worn from morning to evening. Putting them on after dinner provides minimal benefit because most of the pooling has already occurred. The benefit accumulates across the full day of compression. Removing them at bedtime is fine. The fluid that was prevented from pooling is not available for redistribution regardless of whether the stockings are on or off during sleep. Walking activates the calf muscle pump. The rhythmic contraction of the calf muscles during each stride compresses the deep veins and lymphatic channels, driving fluid upward against gravity. Regular walking throughout the day reduces the total interstitial fluid accumulation by augmenting the venous and lymphatic drainage that passive standing or sitting cannot provide. The viewer who walks regularly pools less fluid than sitting all day and produces less nocturnal urine as a direct consequence. Combination daily walking to reduce pooling, compression stockings to prevent what walking cannot clear, evening elevation to pre-process what accumulated, despite both addresses the mechanism at 3 points in the chain. Each point independently reduces the volume that arrives at the kidneys at 2 in the morning. Diuretic medications prescribed for blood pressure or heart failure interact with this mechanism in a way the timing of the dose determines. A diuretic taken in the morning produces its peak effect during the day, processing fluid while you are awake and able to urinate conveniently. A diuretic taken in the evening produces its peak effect during sleep, compounding the nocturnal ANP-driven diuresis with a pharmacological diuresis, filling the bladder faster. The viewer, whose doctor prescribed a diuretic and who takes it with dinner, is adding a pharmacological fluid dump on top of the gravitational fluid dump. Taking the diuretic in the morning separates the two. The pharmacological effect clears during the day, and only the gravitational effect operates at night. The timing change is worth discussing with the prescribing physician. Caffeine afternoon follows a similar logic. Caffeine is a mild diuretic with a half-life of 5 to 6 hours. Caffeine consumed at 3 in the afternoon is still producing diuretic effect at 8 or 9 in the evening, when the kidneys should be transitioning to conservation mode for sleep. The diuretic effect is modest, but additive. It compounds the gravitational redistribution effect that will arrive at 2 in the morning. Caffeine before noon clears its diuretic effect before the evening conservation window. Heart failure produces a severe version of this mechanism, and the severity reveals the mechanism's full extent. In heart failure, the weakened heart cannot maintain adequate cardiac output during the day, and the kidneys receive reduced blood flow during the day. When lying down at night, the reduced gravitational load on the weakened heart allows cardiac output to improve, renal blood flow increases, and the kidneys begin processing the fluid the heart could not handle during the day. The nocturia of heart failure can produce 2 to 3 liters of nighttime urine volumes that produce 4 to 6 awakenings per night. The mechanism is identical to the gravitational redistribution in a healthy person, amplified by the cardiac limitation that prevented daytime clearance. If nocturia has increased significantly over a short period, going from 1 awakening to 3 or 4 within months, accompanied by worsening ankle swelling, shortness of breath when lying flat, or the need to sleep propped up on pillows, report these symptoms to your physician. The cluster may indicate early heart failure, where the nocturia is the most noticeable symptom of a cardiac output problem producing the fluid overload the kidneys can only process at night. Sleep architecture suffers from each awakening in a way that compounds across the night. Each urination-driven arousal interrupts whichever sleep stage was in progress. You must progress back through lighter stages before returning to deep sleep or REM, and the total time in the restorative stages decreases. 2 awakenings per night may reduce deep sleep by 20 to 30%. 3 awakenings may reduce it by 40%. Fatigue attributed to aging, to poor sleep quality, to just not sleeping well anymore may be substantially the consequence of gravitational fluid redistribution, fragmenting the sleep architecture 3 to 4 times per night, a mechanical, addressable problem disguised as an inevitable decline. Deep sleep is when the brain's lymphatic system operates at peak capacity, flushing the metabolic debris that accumulates during waking hours. Each interruption shortens the clearance window. Across months and years of fragmented sleep from nocturia, the cumulative reduction in waste clearance may contribute to the cognitive decline attributed to aging rather than to the bathroom trips that have been silently shortening every night's deep sleep window. The cardiovascular consequences compound separately. Each awakening produces a transient sympathetic activation that is modest individually but cumulative across years of nightly fragmentation. Fall risk is the most immediate physical danger, and it is dramatically underappreciated. Getting up in a dark bedroom at 2 in the morning, navigating to the bathroom while half asleep, with reduced blood pressure from lying down and reduced proprioceptive awareness from interrupted sleep, is one of the highest risk activities adults over 65 perform regularly. Nighttime bathroom trips are among the leading causes of falls in older adults. The fall does not happen because of the bladder. The fall happens because the gravitational redistribution that filled the bladder also reduced blood pressure through AMP-mediated volume reduction, and the transition from lying to standing produces orthostatic hypotension, a drop in blood pressure that causes dizziness, visual darkening, and instability that peaks in the first 15 to 30 seconds of standing. The viewer who felt dizzy getting up to pee was experiencing the cardiovascular consequence of the redistribution at the exact moment they were navigating furniture in the dark. Practical adaptation. Sit on the edge of the bed for 30 seconds before standing. Allow the baroreceptors to register the positional change and adjust vascular tone before the full weight of standing arrives. A dim night light in the hallway and bathroom provides enough visual information for safe navigation without producing the bright light exposure that suppresses melatonin and delays return to sleep. Bright light at 2 a.m. suppresses melatonin and delays return to sleep, a circadian disruption on top of a sleep fragmentation on top of a fall risk, all originating from the fluid that gravity deposited in the legs 14 hours earlier. Salt intake affects the daytime pooling through a mechanism the elevation protocol cannot address directly. High sodium intake increases plasma volume. The kidneys retain water to dilute the sodium concentration, expanding the total circulating volume. More circulating volume means more hydrostatic pressure at the ankle capillaries, which means more fluid driven into the interstitial spaces during the day, which means more fluid available for nocturnal redistribution. The viewer who eats a high-sodium dinner restaurant food, processed meals, preserved meats and wakes more frequently that night may be observing the sodium volume expansion compounding the gravitational pooling. The sodium effect operates on a different timescale than the water intake effect. Sodium retains water for 24 to 48 hours, so last night's salty dinner may affect tonight's and tomorrow night's nocturia, not just the immediate evening. Reducing sodium intake below 2,000 milligrams per day produces a measurable reduction in total plasma volume across weeks. Less volume, less hydrostatic pressure, less daytime pooling, less nocturnal redistribution. The dietary change is slow but cumulative, and the effect compounds with the mechanical interventions. And then alcohol, because it operates on the nocturia pathway through two mechanisms simultaneously, and the dual effect explains why alcohol produces the worst nocturia nights despite producing the most drowsy sleep. Alcohol suppresses ADH release from the posterior pituitary, the hormone that tells the kidneys to conserve water during sleep. With ADH suppressed, the kidneys shift to dilute urine mode regardless of volume status. This pharmacological diuresis runs on top of the gravitational AMP diuresis, both mechanisms commanding the kidneys to dump fluids simultaneously through independent hormonal pathways. The bladder fills from two directions: the gravitational redistribution producing AMP-driven diuresis, and the alcohol-producing ADH-suppressed diuresis. The worst nocturia nights are alcohol nights, not because of the fluid volume consumed but because two independent hormonal pathways are both driving renal output simultaneously. Occupation determines the severity of the daytime pooling more than most people recognize. Standing occupations, retail workers, surgeons, teachers, factory line workers produce the most severe pooling because the hydrostatic pressure column, from heart to feet, is maximally loaded for the full working day with minimal calf muscle pump activation. Sitting occupations produce moderate pooling. The hydrostatic column is shorter because the legs are partially elevated, but the calf muscle pump is inactive. Walking occupations produce the least pooling. The calf pump drives continuous venous and lymphatic drainage that partially compensates for the hydrostatic pressure. Retirement changes the equation unpredictably. The retired viewer, who was a postal worker walking all day, pooling minimal fluid switches to a sedentary retirement of sitting, reading, and watching television. The daytime pooling increases because the calf pump that their occupation provided for decades is no longer operating. Nocturia that was absent during the working years appears during retirement not because of aging alone but because the occupational calf pump was removed. The retired viewer who adds a daily walk is partially replacing the calf pump their job used to provide. Well, the anxiety loop, because the mechanism creates a self-reinforcing cycle you may not recognize. Waking at 2 a.m. produces frustration and anxiety about sleep quality. The anxiety produces cortisol release and sympathetic activation that delay return to sleep after the bathroom trip. The delay reduces total sleep time, which increases next day fatigue, which increases next evening anxiety about whether tonight's sleep will also be interrupted, which produces pre-sleep sympathetic activation that itself delays sleep onset, reducing the time available for sleep before the 2 a.m. redistribution arrives. The cycle feeds itself. The nocturia produces the anxiety that worsens the sleep, that worsens the experience of the nocturia. Breaking the cycle requires either reducing the nocturia through the mechanical interventions or reducing the anxiety about the nocturia by understanding that the awakening is a physics problem with a physics solution rather than a sign of declining health. Elevation protocol deserves practical detail because the logistics determine whether anyone actually does it. A wall works lie on the floor or bed with buttocks against the wall and legs extended vertically up the wall surface. Pillows work 2 or 3 firm pillows under the calves and ankles, elevating the feet above heart level while lying flat. A recliner works the footrest elevated to maximum, though most recliners do not achieve true above heart elevation. The key is that the feet must be above the level of the heart, not just elevated from the floor. Legs on a coffee table while sitting in a chair does not produce the full redistribution because the feet are not above heart level. The hydrostatic gradient is reduced, but not reversed. 30 minutes is the practical minimum. If you can manage 45 minutes while reading, watching television, or listening to a podcast, the additional 15 minutes captures more of the pooled fluid. The diminishing returns begin after approximately 45 minutes. The majority of the accessible interstitial fluid has drained by then, and the remaining fluid requires the full 2 to 3 hours of horizontal redistribution that sleep will provide regardless. Elevation should end with a bathroom trip. The urine produced during elevation is the leg fluid being processed while you are awake and the bathroom is accessible. Skipping the post-elevation urination defeats the purpose. The kidneys process the fluid, it is sitting in the bladder, and if you go directly to bed without emptying, the bladder is already partially full when the remaining nocturnal redistribution adds to it. Elevate, urinate, then bed. The sequence matters. That mechanism: 14 hours of gravity depositing fluid, 3 hours of horizontal redistribution, the heart commanding the kidneys to dump it, explains every 2 a.m. awakening I blamed on water intake for decades before the leg fluid made the timing make sense. Bladder training: the advice to hold it longer during the day to increase bladder capacity addresses a mechanism that is not the primary driver for most nocturia in adults over 50. Bladder training increases the volume the bladder tolerates before signaling urgency. If the problem were a small bladder that cannot hold a normal volume, bladder training would help. But the problem for most adults with gravitational nocturia is a normal capacity bladder receiving an abnormal volume of urine between midnight and 3. The bladder capacity has not decreased, the urine production has increased because the heart is commanding the kidneys to dump the redistributed leg fluid. Training the bladder to hold more delays the awakening slightly, but does not reduce the volume arriving. The intervention targets the container when the problem is the supply. Bed partner observes something the nocturia sufferer often misses the pattern. You got up 3 times last night carries clinical information that the sleeper, who was groggy during each trip, may not register. The partner who tracks the number and timing of awakenings across a week provides data that helps distinguish the mechanisms, awakening at 2 and again at 4. With large volume dilute urine each time, is the gravitational redistribution pattern. Awakening every 90 minutes with small volume urgency is the outlet pattern, prostate or pelvic floor. Awakening once with large volume dilute urine that resolves after leg elevation is the gravitational pathway responding to the intervention. The partner's observation is a low-cost diagnostic that many physicians would value but few think to request. Long-haul flights compound the mechanism through immobility. Hours of sitting in a cramped seat with legs below heart level and no calf muscle pump activation produces aggressive fluid pooling. The flight arrives, you go to bed in the hotel, and the redistribution dumps hours of immobility accumulated fluid into the kidneys. The first night after a long flight often produces the worst nocturia of the month because the pooling volume was amplified by the duration and severity of the immobility. Walking during the flight, compression socks, and 30 minutes of leg elevation at the hotel before bed address the mechanism at its origin. After years of treating the 2 a.m. trip as a bladder problem, the source was below the knees the entire time, and the intervention was 30 minutes of doing nothing with my legs above my heart.